Hi, everyone. My name is Zainab Azadeh Raja. I'm the Resource Development Associate at the Immigrant Women's Information Network. I'll be moderating the session today. On behalf of the IWIN team and staff, we welcome you to today's webinar, Not the Default, Centering Racialized Immigrant Women in Healthcare Research. IWIN is a membership-driven nonprofit organization that represents and provides information to immigrant women. We apply an intersectional lens to the work that we do and envision a society where immigrant women, trans women, non-binary, two-spirited, and gender-diverse individuals experience complete racial and gender equity. Before we move forward, I want to emphasize that for IWIN, this isn't just research talk for us. In Canada, we see immigrant and racialized women who are constantly trying to navigate systems that don't always see them clearly or take them seriously. For Indigenous communities, this has been long-standing. Indigenous women have been harmed by these same systems for generations, and that harm is tied to colonization. So for us, this work also means showing real respect, learning, and standing alongside Indigenous communities in meaningful ways. That said, we want to keep pushing for healthcare and research that is fair, accountable, and shaped by the voices of the women who are most impacted. I am pleased to introduce you to our partner in this webinar. We are hosting this webinar in collaboration with the Women's Health Awareness Movement, a student-led initiative at McGill University. They work to advance healthcare for women, gender, and sexual diverse individuals through education, outreach, and partnerships across the healthcare community. We're also very happy to be joined today by two members of the WHAM team, Maria Vintilla and Zoe Freyret. Maria and Zoe will be speaking on behalf of WHAM and sharing insights from their work, including how WHAM is helping to raise awareness on key women's issues, including endometriosis, breast cancer, and women's heart health. Thank you so much for being here with us and for partnering with us. We also have Dr. Ananya Banerjee here with us today. Dr. Ananya Banerjee is an assistant professor and the Equity, Diversity, Inclusion, and Anti-Racism lead at the School of Population and Global Health at McGill University. Her interdisciplinary epidemiological and qualitative research uses community-based participatory approaches to address health inequities using a structural and intersectional lens. Before we move on to the panel discussion, I'd like to bring in my colleague, Nahid Khan, for a short presentation on why representation in health research matters and how gaps in research can lead to poorer health outcomes for racialized immigrant women. As each presentation is being delivered, we kindly ask that you type in your questions into the Q&A chat box. We'll address your questions during our Q&A session in the last 15 minutes.
Hi, everyone. My name is Nahid. I work with the Immigrant Women's Information Network as a communications and marketing specialist. I also have a nursing background. So I completed my Bachelor of Nursing at Toronto Metropolitan University in 2022. So a little unique thing about me is that I've had one foot in the nonprofit world for a long time. I've been working in community and nonprofit spaces since I was about 16, and I've also worked in multiple healthcare settings. So, from what I've seen firsthand, many racialized immigrant women don't always understand what's happening in their bodies right away. Not because, of course, they don't care, but because there are real barriers. So, sometimes it's language gaps. They don't have the words to describe symptoms clearly. Sometimes it's cultural, like being raised to push through pain or not feeling comfortable talking about certain symptoms. And because of that, they may not seek help early, or they may not understand even when they do. Even when they finally get the care that they do, it can be turned into delayed care, which often means the problem has become more serious. So as you can see from the title, Evidence is the building block for how we respond to health. Research, whether that is clinical trials or a health report, it does become the message about what to watch for, our clinical guidelines, screenings, diagnosis, and what even counts as urgent and triage. So when racialized women are underrepresented, gaps show up everywhere. For example, clinicians may interpret symptoms differently, or they may dismiss them even faster, which may result in racialized women delaying help seeking because sometimes the messages just don't feel right for them. The response that they may receive may be even a little slower, less thorough, or even less culturally safe. So I'm going to be sharing one Canadian example that really ties this down. When research is more inclusive and actually reflects women's lives, especially racialized immigrant women, it just doesn't improve healthcare. It also changes how racialized women address their needs. So according to the Heart and Stroke Foundation of Canada's 2023 report, in about half of women who have a heart attack, the symptoms aren't recognized. And every 60 minutes, a woman in Canada dies from a heart attack or stroke. So the report also emphasizes that symptoms from women get labeled as atypical or low risk because a lot of risk models and evidence were actually developed and validated mainly in men. So now for racialized immigrant women, the risks and outcomes can be even worse, not simply just because of biology, but just because of how context shapes care. So, for example, as we mentioned earlier, language barriers can affect how symptoms are described and understood. Social factors like income insecurity, lack of paid time off, childcare strain, transportation, sometimes the fear of not even being understood. These can mean that these symptoms are minimized or handled later than they should be. So essentially, the absence in research turns into the absence in care, which can result in missed signals, delayed pathways, and even unequal health outcomes. So the takeaway for my short presentation is simple. Representation in research is not simply just checking up the boxes or making sure that we're hitting all the academics. It's also that we need to be proactive. So if we want evidence that fits women's lives, we also need to make sure that racialized women are also included in what counts as evidence in the first place. I hope you did learn something from my very short presentation. Thank you so much for everyone attending today's webinar, and I'll hand it back to Zainab.
Thank you, Nahid, for your insightful presentation. You've clearly outlined how gaps in research and, as a result, representation create real barriers for women seeking care. Now, building on this foundation, we'll turn to the work that's happening at the community and advocacy level. WHAM, we now invite you to present.
Hello, everyone. Thank you so much for taking the time out of your day to be here with us today. It's such a pleasure to get to talk to you about such an important issue. My name is Zoe. I'm a second-year medical student at McGill, as well as the lead vice president of external affairs for the Women's Health Awareness Movement. So today, my colleague Maria and I will be talking a little bit about our club and what we do, as well as the general healthcare for immigrants and refugees who come to Quebec and Canada. So I'll begin with a land acknowledgement for where Maria and I are presenting from today, which is McGill. So McGill University is a land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabeg nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. I'll now pass it on to Maria to describe what we're going to be talking about today.
So thank you, Nahid and Zoe, for this lovely introduction. So here's quickly our roadmap for today. We'll start with a little bit about WHAM, and then why this collaboration with IWIN makes sense. We'll then go into some stats from an interesting article, and finally, Zoe will talk about accessing care in Canada as a refugee or immigrant. Next slide. So let's start with the basics. What is WHAM and why does it exist? So in medical school, we learn a lot about disease. We don't really learn about how gender, culture, and how systems shape who actually gets care and who doesn't. So WHAM, which stands for Women's Health Awareness Movement, was created in response to a simple but persistent reality in medicine. Women's health is still under-researched, under-taught, and under-prioritized, whether that's due to allocation of funding grants or insufficient training. Next slide, please. So now let's look at some past things we've done that have helped to bring women's health to the front of medical education. So coming up soon, we have the Circles of Cervical Care PAP Clinic, which are basically these mobile PAP clinics that will help women who otherwise would not have had access to rapid screening to receive an essential service in a safe and respectful environment. And then also for the last few months, WHAM has been animating these women's health circles, which are basically activities where women can get together and talk about their vulnerable situations and help each other. And over the last 2 years, WHAM has done multiple awareness campaigns, including one for Indigenous health and one for abortion rights. And we, as a club, have been able to crowdfund almost $20,000. So next slide, please. This Venn diagram was just to show why this collaboration just makes sense. So WHAM, as you see on the left, focuses on women's health education and advocacy, while IWIN focuses more on informing immigrant women of the resources available to them. And this overlap in the middle is exactly where real impact happens by addressing systemic barriers and fighting for equitable health. So thank you all for being here despite your busy calendars and supporting us in this first step in our big mission. So next slide, please. Before we go any further, I'd like everyone to take a moment to think about 2 questions. So what does good healthcare look like to you? And what happens when the system doesn't reflect your culture or values? So with that in mind, I would like to show you an article that I found really interesting recently. Next slide, please. So this Canadian research looked at how well migrant-friendly maternity care, which is termed MFMC, was delivered to recently arrived international migrant women giving birth in 4 Montreal hospitals. It focused on access to prenatal care, communication, healthcare provider support, and respect for women's care preferences using a standardized questionnaire. So of 847 women who needed interpreter services, 84.7% reported not being offered any interpreter services. And women with lower language ability also experienced poorer support from healthcare providers and less responsiveness to their preferences during labor. So this article just goes to show how social determinants really do affect access to healthcare, because it showed that women were less likely to receive early or adequate prenatal care if they had arrived more recently in Canada, had lower household income, or had less education. So now I'm going to pass it on to Zoe, who's going to talk about how these newly arriving women can get access to healthcare in Quebec.
Thank you, Maria. So I want to discuss the steps to accessing healthcare for asylum seekers and refugees to Quebec to illustrate the bureaucratic complexities one might face upon coming to Quebec. I'll be speaking in the second person, so you might easier put yourself in the shoes of somebody coming into Quebec. So first step, becoming a refugee. Before you have accepted refugee status, you are called an asylum seeker or a refugee claimant. You can claim asylum either abroad, at the Canadian border, or from within Canada. Before you have refugee status, you do not have access to provincial healthcare, such as RAMQ in Quebec. Instead, your healthcare is covered by the IFHP, which is the Interim Federal Health Program, which is administered by Blue Cross. Healthcare providers are not always aware that refugee claimants have access to this coverage, which may lead to refugee claimants being unduly charged for the healthcare that they are owed. So healthcare workers should be educated on this and should charge Blue Cross directly, since asylum seekers may not have a health card when they come to the clinic and may not be aware of their access to this care. When and if a person gains refugee status, they're then eligible for provincial coverage. Asylum seekers and refugees can receive care anywhere, so whether at the hospital level or at the clinic. Next slide, please. In terms of access to both the IFHP and provincial healthcare, it is of note that there are some limitations to access. First of all, only certain vulnerable groups have access to the IFHP, notably refugee claimants, which are protected persons in Canada, as well as other groups of protected persons, such as victims of human trafficking. In terms of immigrants to Canada, most do not have access to the IFHP since they don't fit under the vulnerable persons category. Once immigration status is approved of, it can take people up to 3 months to acquire a provincial health card. As such, the Government of Canada recommends that newcomers secure private insurance during the waiting period, which is, as you can imagine, inaccessible for some. Next slide, please. There are currently many barriers when it comes to accessing quality primary care in Canada for asylum seekers, refugees, and immigrants. First of all, there's a limited access to the IFHP and a lack of education on this topic amongst healthcare providers, which leads to uncertainty about coverage as well as possible unnecessary medical bills for newcomers. Oftentimes, this population will not advocate for themselves and may not be aware of their right to access care. As such, it is up to healthcare providers to recognize that treatment for asylum seekers is covered by the IFHP and Blue Cross. Moreover, of course, there oftentimes exists a language barrier between patient and healthcare provider. The lack of interpreters and language difficulties increase the risk of misdiagnoses, poor patient understanding of their condition and adherence to prescribed treatment, lower satisfaction and confidence in their treatment, as well as differences in the treatments that they are prescribed. All of this is detailed in the Winnipeg Regional Health Authority. Another issue is a lack of culturally competent care. So in Canada and many other destination nations, the dominance of Western biomedicine fails to acknowledge the social and cultural basis of health, which puts those from different social milieux at a disadvantage. Next slide, please. Amongst newcomers to Canada, women and girls are particularly vulnerable. Over 50% of female victims of domestic homicide in Canada are Indigenous, immigrant, or refugee women. Moreover, immigrant women, especially those with precarious status, are more vulnerable to conjugal violence. It is important to note that the more vulnerable a person is, the less likely they are to call the police or seek help, which may perpetuate the circle of violence. Due to many factors, such as language barriers, social isolation, lack of access to immigration papers, lack of financial autonomy, and the unawareness of an existence of a family allowance in Canada, women who come to Canada as either refugees or immigrants are particularly vulnerable to coercive control by their spouse in the context of domestic abuse upon arrival to Canada. So, these realities and intersecting barriers underscore why WHAM is committed to advocacy, education, and action, amplifying the voices of vulnerable women and working towards a healthcare and social system where insecurity is met with protection and not silence. Next slide, please. So where to find us? I've linked our Facebook as well as our Instagram and LinkedIn. If you're in the Montreal area and you're interested in volunteering with us, you can check out the opportunities we have on Instagram. And if you're just generally interested to see what we have going on at WHAM, we would love to see you over on our Instagram and Facebook pages. So I'll pass it over back to Zainab. Thank you so much.
Thank you for your presentation and for sharing the work that your organization does, especially raising awareness on existing resources and highlighting the gaps that currently exist on the ground level. Now, to complement this perspective, we'd like to invite Dr. Ananya to share her research.
Hi, everyone. Thank you to WHAM and the network for giving me the opportunity to speak. Actually, I just really want to start off and give gratitude to my mother and my grandmother, who I'm very close to and raised me and are both immigrants here to Canada. And, you know, I've had the opportunity to really witness their experiences in the health system for several decades. And I just want to acknowledge and give much love to my mom and grandma for, you know, just giving me the opportunity to learn and hear their stories and how they navigated many complex problems in their lives that include stroke, cancer, and so forth. And so for the next 15 minutes, I'm really going to be giving a political, economic snapshot of why are racialized immigrant women to this day continuing to experience health disparities. Next slide, please. I think I just really want to go back to 1847 and a well-renowned social medicine physician, Rudolf Virchow, in 1848, recognized that medicine was actually, in this context, in that day of age, a female or a woman. And I'm saying from a social construction lens. I think this is important for us to acknowledge, especially during the times of the 1800s, that it was well recognized that medicine, in order to fulfill her a great risk that she must enter the political and social life. And questioned to everyone at that time, where the field was pretty much dominated by males globally, do we not always find the diseases of populace traceable to defects in our society? Next slide, please. So why do we want to focus on racialized immigrant women? I think it's important to first define who is a racialized immigrant woman. These are women, again, who are non-binary individuals, also are quite gender diverse, are actually immigrants and experience racialization. It is not because of their race. And that is really shaped by their experiences of racialization that intersects with their gender identity, their migration status and class, and many other social identities that we can name. We are focusing on women, and this has been work that has been pioneered for decades now. Because when we think about women's health, it is gendered from a political lens. Whether it's reproductive, maternal, mental health, endometriosis, heart disease, diabetes, how women were disproportionately impacted by COVID-19, we need to really critically think, why does this continue? And something that I often offer as a different lens to everything that has been shared thus far is that women in themselves have a disproportionate amount of caregiving roles and unpaid labor that is often not recognized and not seen as a social determinant of health. And so I think the key point I really want to highlight is when we're thinking about access to healthcare for racialized immigrant women, it is truly shaped by intersecting systems of racism, sexism, patriarchy, misogyny, and immigration control. And in order for health equity to be truly achieved, which has been a struggle from the early 1800s, is that we need to strive to engage in anti-racist, anti-oppressive practices, really take an intersectional feminist lens, and most importantly, engage in decolonial principles. Central to these efforts is also our commitment to active solidarity with First Nations, Inuit, Métis women, girls, and Two-Spirited peoples. Next slide, please. And so I provide you this visual to just really understand the most complexity and how nuanced and layered when it comes to understanding why racialized immigrant women continue to face severe disparities. It's really driven by our social and structural context. I have to admit, I do get sometimes frustrated when it is often attributed to cultural factors. While I believe culture is absolutely an important determinant of health, I think it's important to understand that the research to date has actually portrayed culture from a deficit lens. And there has been a lot of shame and blame on cultures of diverse racialized immigrant women. And so if we continue to just focus on culture from a deficit lens and not actually flip the narrative, where actually culture is a major strength for women in terms of managing and their health, but also preventing severe health outcomes, we need to really understand also how can culture facilitate healthcare access. And so coming back to this framework, again, visually, just showing the complexity of trying to understand why racialized immigrant women continue to experience health disparities, we really need to understand it from a social structural context. The reality is that women's health operates within broader structures, and we need to understand the migration pathways that includes family sponsorship, caregiving, domestic work, temporary labor, and often understanding that labor in itself is gendered, given that many racialized immigrant women are concentrated in low-paid, precarious work, and they have very limited health benefits and job production. Yet they continue to work in economic conditions that are quite adverse to their health in order to make economic ends meet for themselves and their families, and often their extended families back home. And so with that, women, racialized immigrant women, the evidence shows, are more likely to report social isolation, due to language barriers, but also limited networks, and also having dependence on partners or employers. When we think what this framework is also showing is when it comes to understanding women's healthcare needs, often what needs to also be addressed is the legal and immigration related barriers that was shared, that lack of eligibility for public health care due to their status, which is obviously most severe for those who are undocumented refugees or asylum seekers. Also, there continues to be a dependency on spouses or employers for legal status. And we need to really also focus on women who are single parents, who are divorced, and so forth. And then often we need to also understand that many women who are racialized based on their migration status are actually delaying access to care because they're reluctant to access care in fear of immigration enforcement when seeking care. I did touch upon economic barriers, but really want to also reinforce that given that women who are racial, I mean, all women, but especially who are racialized and immigrants, they often, because of their jobs, they actually are not able to have access to paid sick leave and also child care. And with that, if you don't have, health insurance, there are severe cost barriers for medications, prenatal care, and mental health services. With that, we have to think about the medical bias within our healthcare system that is very rooted in racism, sexism, and patriarchy. And often these women are exposed to stereotypes that includes assumptions to pain tolerance, fertility, compliance, dismissal of their symptoms, particularly when it comes to pregnancy and childbirth. And we know this is very well renowned in African American communities in the US, for example, and Black immigrant women. And essentially, women who are racialized and an immigrant can continue to experience disrespect, coercion, and a lack of informed consent within our health system, which unfortunately leads to a lot of violence and safety concerns as well. Next slide, please. And so I think what's also important to take note is that often when we think about understanding through research, through practice, through implementation, trying to understand why health disparities exist among racialized immigrant women, often it does also continue to take a one-size-fits-all approach. And we really need to take an intersectional lens. We need to really understand that it is not it's not women who are racialized and are immigrants. It's not because of their race, gender, and migration status. Sorry, it's because these social identities that we self-identify at the individual level are linked to greater multiple systems of oppression that actually operate simultaneously. And so women who are racialized and are migrants, it's because they, again, experience patriarchy, misogyny, like all women do. But this is added layer of racism and xenophobia, and we can even take it further to Islamophobia if they're visibly Muslim, for example. And these interactions just compound the effects and deteriorate their health alongside with not getting access to healthcare that is actually dignified. And so healthcare experiences do differ from those of immigrant men and non-immigrant racialized women as well. Immigration status creates very strong gender vulnerabilities. And again, coming back to clinical encounters, often healthcare professionals, when you look at intersectionality, many of them are actually centered in the middle, right? Where they have very unique circumstances of power, privilege, and identity. And that even includes physicians who are racialized, for example. I think what we need to really start to understand and deepen is how colonization, politics, globalization, capitalization, war, and so forth is actually perpetuating the health risk of racialized immigrant women, especially where they come from geographically here in Canada. And so intersectionality actually improves policy and practice because it shifts away from the focus from individual behavior to structural causes of inequities. And we need to have more of a push for policies and healthcare models grounded in intersectionality that are more responsive, equitable, and effective. And we really need to stop taking a one-size-fits-all approach. Because if we don't take an intersectionality lens, as Dr. Kimberly Crenshaw, who coined this term, that stemmed from critical race theory, is that those who are most vulnerable and have compounding identities and are part of these compounding systems of oppression are going to continuously continue to fall through the cracks. Next slide, please. And so the key point I also want everyone to get out of this is that when we think about women's health access, it is extremely political. Again, often we mostly focus on socioeconomic positioning, material circumstances, biological and behaviors and psychosocial factors, and why these are absolutely important, given we know that health access is so multifactorial, layered, and so forth. We really need to actually start working towards a human rights lens. And that is, we need to look at our macroeconomic policies, especially in a state like Quebec, look at our social policies in addition to our health policies, public policies that include education, social protection. And we need to value the cultures of these communities and really instill the societal values that they hold as well. And so if we don't take a governance stance, if we don't hold our governments accountable, and if it's not part of the political agenda, especially during re-elections, which is coming out, given that Francois Legault did resign yesterday and will not work towards re-election, given that we are going to have a new leader in Quebec, let's really think carefully and let's look to see if women's health from an intersectional lens, particularly those who are most vulnerable based on their race, gender, and most importantly, age. We know that ageism is a huge issue, and racialized immigrant women who are seniors are even more vulnerable within our health systems. Let's make sure it's on their agenda, and let's see if they hold themselves accountable. Next slide, please. And so with that, this was actually touched upon from WHAM, and I really appreciate them giving this context, and I won't spend too much time on it. But given the language laws that we have here in Quebec, we need to actually understand that actually drives often people's opportunities to access to interpreters. And as much as we've come a long way, for example, using AI technology to ensure interpreters are being offered to women, and understanding it, often even racialized immigrant women who are able to speak English and or French, they should have the choice to be able to communicate in the language that they are most comfortable with. It often doesn't even come down to fluency. And so they should be given the choice to have an interpreter because they feel more comfortable to be able to talk about their medical needs in their native language. And so what's really promising right now is that immigrant women who are racialized themselves have begun to stand up to the government. And that's what we need more of. We need to work alongside with them as allies, as co-conspirators, and have their voices raised as opposed to us always trying to advocate for them or be on behalf of them, and trying to bring their experiences, which we may necessarily not fully understand because we are quite privileged. And so there is a whole movement happening for where immigrant women in particular are calling for better interpreter access during births in Quebec City hospitals. And again, this is a political move because it's really addressing unequal access, biased research, discriminatory policies that shape care, And when we think about these discriminatory policies, it again is rooted in our language laws here in Quebec. And so reproductive rights, maternal maternity, pain treatment reflect power, racism, and history. That's really, really important. And I didn't have a chance to go into history. But what is happening now is no different often from what has been happening for centuries among women globally, particularly those who are immigrants and racialized. And what this really comes down to is decisions about bodies exposed, whose lives are valued, funded, protected, and believed by institutions and governments across our systems, laws, and cultures. Next slide, please. And so as I begin to wrap up, I do want to, end on a bright note. And, I wish I had more time because there are actually incredible stories where immigrant racialized women are at the forefront and creating real change, but not for themselves, but for all women. And so some promising practices and solutions that I have been inspired by, particularly by Women's Health and Women's Health and Women's Hands Community Health Center in Ontario, is that first and foremost, we need to have policy level interventions. We need universal healthcare access regardless of migration status that needs to be independent and independent legal status for women who are experiencing abuse within our health systems, expanding maternity and reproductive health coverage. In terms of healthcare system strategies, we need to have more gender and race conscious care models, again, guided and led by women who have those lived experiences. And we also have to have our healthcare physicians to engage in mandatory anti-racism, anti-oppression, and trauma-informed training. These women carry a lot of trauma, especially if they're coming as refugees and asylum seekers. And this trauma is unfortunately carried on from their host country, which is amplified once they arrive to Canada. And we need guaranteed access to professional interpreters. Most important, we need to take community-based and feminist approaches. So this needs to be women-led, especially those who have experiences of migration and are racialized. And they need to be culturally specific. And when I talk about culturally specific, culture needs to be seen as a strength, not as a deficit. And community health workers and doulas, and obviously this is the context of reproductive health, need to also come from immigrant communities as well. And essentially, we need to strive to have as many, not just safe, but brave spaces for integrating healthcare, legal, and social supports where immigrant racialized women will see that they are part of the solution and that their voices will be heard and they will be leaders of change and have the autonomy and agency to reimagine a healthcare system that is truly deserving for them, but again, for all women here in Canada. Thank you so much.
Thank you for this presentation. Seeing how structural and social factors intersect and determine how health is accessed by racialized women is really very interesting. Your statement about politics being at the forefront of healthcare access is something we should carry with us as we continue to understand and challenge why health disparities exist. Thank you again for sharing, Ananya. Now, to connect advocacy, research, and lived experiences, we're going to be moving on to the panel discussion portion of today's webinar. Our first question is posed to both WHAM as well as Ananya. Can you expand on how structural racism and gender bias influence preventative health research across the research continuum? From early stages such as the selection of research topics, funding priorities, and study design, to later stages where clinical trials are conducted and findings are translated into clinical guidelines that then shape how care is provided.
Oh, I was going to say WHAM can start.
Sure. So in terms of like research and project development, I guess I can speak to my own personal experience. So I'm a second year medical student. I don't have too much experience in research, but the project that I did over the summer did have some inclusion criteria. And one of them was language. So we created a patient decision aid, which is an educational tool used in clinic to educate women on their condition. I worked in the sphere of gynecology. So to be part of the study, the women had to speak English and French. This was largely due to the lack of interpreters, also the lack of access to a translation service to create the PDA and then have the PDA approved by the REB. So that obviously limits the data we have to women who are fluent in both languages. Another inclusion criteria was having to have access to an email account or a phone number in order to contact these patients, which if you're a newcomer to Canada going to a gynecology clinic for the first time, you might not have an established email account or a phone number. So those are some examples. In terms of research funding and priorities, I don't have too many experiences in that. I don't know if Ananya, you'd like to speak on that.
Yeah, I mean, if you think about, our tri-council funding agencies here in Canada, such as the Canadian Institute of Health Research, Social Science and Humanities Council. We also know, for example, Heart and Stroke, Canadian Cancer Society actually has a dedicated funding towards equity and often focused on the health of women. Particularly, they are more than happy to invest more in the health of immigrant women from an intersectional lens. I think what personally has been really frustrating is often academics are engaging in this research and their intentions are absolutely real and they really want to advance health equity. But something that I see over and over again is often, particularly when it comes to immigrant women, is that they're not involved from the beginning, which is important. And I think for any research to move forward, the research question has to be co-developed and co-designed by immigrant women themselves to ensure that the research question is a question that they want to have asked. And then most importantly, the research will not just give them more in-depth understanding of disparities, but actually will lead to solutions. And so with that, they need to start from the beginning and, be part of the entire research cycle. Often a lot of projects have, for example, a qualitative component, and we're seeing more and more research projects that are actually employing immigrant women, especially those who can't find jobs, who are co-researchers and are actually doing the interviews within their communities. They are also being able to conduct the research, whether it's surveys and so forth, in different languages. But most importantly, I think we need to understand that we have to take we need to also ensure data governance. And so this data that is produced, the goal is not to just have it published in a peer-reviewed journal, but how do we actually make sure this data is given back to the communities of women who are immigrants and or racialized, so they can use the data to advocate for themselves as well. Many of them share very vulnerable stories but I think we need to be more intentional, ensuring that we are taking a really strong, not community engaged approach, but a community partnership approach, and that these women are seen as experts in the research process and guided and govern it, and to make sure it actually benefits them and not harms them further, and also be paid for their participation equitably as well.
Okay. Thank you for sharing your responses. This really goes to show that research doesn't just dictate policies, but it also has real consequences for how people are provided care. Now, both of you have touched upon how racialized women's concerns are often dismissed or minimized in medical settings. What does research tell us about this pattern, and how does it shape long-term health outcomes, especially in terms of whether women feel comfortable returning for follow-up care?
Yeah, so I did a little bit of research on this in the Montreal area, and there's a study that was published in 2024 entitled "A Qualitative Study of Diverse Perceptions of Racism and Racial Discrimination Amongst Black Adults in Montreal, Canada." And I focused on women in particular in this study. So it was qualitative data. So they talked to patients about their experience navigating the healthcare system in Montreal as a visually racialized person. Some things that they mentioned were like racist stereotypes, like particularly about pain perception. So that there's a stereotype that Black women can handle pain better, so they are given less medication to manage their pain. There's also downplaying of health concerns for Black women who came into the clinic. As well as doubting accounts that the women who came in like weren't on long-term medications. There's sort of a stereotype that these populations experience more well, we're taught that these populations experience more diabetes, more chronic heart conditions. So there's a sort of like mistrust in the patient when they come in to describe their history. Yeah, so that's something that I found in Montreal.
Yeah, I mean, just to add, I think again, I think we need to really understand, and I appreciate that qualitative study, but again, taking from an intersectional lens, I just want to offer a story because I think it's very powerful. Right now, myself and Dr. Patricia Lee, who's an incredible pediatrician here in Montreal, are running a randomized control trial for particularly migrant women who have children with complex disabilities, and we are in the phase where we're doing qualitative interviews. And I was listening to one interview actually this week, and it was a young mother who came as an asylum seeker from a country in the global south, which I will not disclose just to preserve anonymity. But I remember when she was telling her story of when she first came to Canada, and because of her child who has complex disabilities, had to enter the health system. And what was really powerful, she had said, is during her encounters, even to this day, how often, she feels she's actually at the immigration detention center in the hospital. And she said there are many parallels between those experiences. And she offered that she feels like she is continuing to just solely be judged as a refuge, as an asylum seeker, and again the experience even worsening, especially as a racialized woman. um, and she said, my biggest fear is that every time I bring in my child, because their health needs need to be addressed, is that I worry that we will be deported. And we asked her, what would happen if you were sick? And she was like, I don't know if I would go, but I have to go because of my child. And that's really frightening, right? And it comes back to our institutions. And they actually have a strong responsibility to make sure that access to healthcare is for everyone, irrespective of who they are. And there should not be a set of fear because this is just going to delay access. And in the context of this woman and many other women like her, if she gets sick, who is going to take care of their child has no choice but to be dependent on them? So I just really wanted to just share that and kind of just bring that nuance. And, I don't know what the answer is, I'll be honest, especially as a very privileged person who, hasn't had much difficulty accessing the healthcare. And so I think we need to bring them in to really inform us and hear their stories. And I think that actually starts from medical school. Like, we need to have more patients coming into the classroom and really sharing their stories and struggles and telling our medical students how they can best advocate with them, not for them, but, prepare them to work with women like her. Thank you.
Thank you so much for sharing. I think it really is so important to consider the connection between initial dismissal and then long-term distrust of care. So this brings us to our third question. As WHAM is comprised of medical students, this next question may be relevant to your learning experience. How early are medical students faced with medical biases in coursework and research opportunities? And to what extent do these biases then go on to impact how medical or frontline workers deliver care to diverse populations? And what are some ways in which the medical community can mitigate these impacts and push for change?
Yeah. So I want to thank Ananya for talking about your study as well as the patient that you spoke to. That was a really inspirational story to hear about. And as a medical student myself, I think it would be an amazing opportunity to have somebody come in and speak to our class about this. We have a lot of patients who come in to speak about their experience navigating various health conditions, chronic health conditions. We don't often have patients coming in to talk about like social inequities and their experience navigating that from the perspective of a woman, from an immigrant, as a mother. So yeah, that would be a super amazing experience for us as medical students. In terms of our introduction to medical bias, we're told when we learn about standardized values that they're based on a reference patient who is a 70 kilogram, 20-year-old white man, like data collected from the 1960s. So we call for research to be done to have more values that take into account various populations. Like the population of Canada as well is very different now. It's composed of different ethnicities and ages and everything than it was at the time. So our standardized values are not exactly accurate or the most useful. In terms of our exposure to various marginalized communities at McGill, we have a chat project, which is the Community Health Alliance project, which allows us to be exposed to various vulnerable groups of people. And we have to write reflections after each encounter to sort of discuss their needs, like what we've learned about their needs, how we could serve them as a healthcare provider, and really hearing from them. So as Ananya was saying, to not advocate on their behalf, but to really collaborate with them to discuss what their needs would be so that we can become the best healthcare providers possible in the future. Maria, do you have anything to add?
No, I think that Zoe did a good job of summarizing everything. I think we're lucky at McGill. We get access to marginalized populations pretty early through the CHAP program, so which is like 20 hours of volunteering, which gives us like a sneak peek into like these populations. We also have like, family medicine exposure. But since we're preclinical students and we only start in the clinical setting like in a few months, we'll see how that goes. And I'm curious to see like exposure in the clinical setting, how that will go, and how doctors deal with like obviously the burden on the medical system and also having to deal with like, Medicare access and everything we talked about today.
Okay, thank you so much for sharing. Now, Dr. Ananya, you already explained this while presenting earlier, but can you expand some more on how intersecting factors such as racism, immigration status, and gendered care norms also shape how women go on to access healthcare?
I did touch upon it quite a bit, but I think storytelling is so powerful, and so I think what I want to kind of come back to is again based on my own mother and my grandma's experience, but also just I did work clinically for 10 years at Women's College Hospital, where I worked as a kinesiologist in cardiac rehab. And I worked with a diverse group of women who had heart disease, and motivating them to exercise. Part of my role was that I did spend often anywhere up to 3 to 4 hours with them per week over a 6 month period. And I think when I think about the women who were immigrants and were racialized, I think what really stood out for me, and again, I had this luxury because I had time to spend with them, is that they just want their stories to be heard and feel validated, right? And I think a lot of immigrant women who are racialized, when they come in and if they start off with, you have to understand how hard my life is, especially, for the mother that I was talking about before, right? Who's an asylum seeker, her husband hasn't arrived yet. She's like trying to get housing. She's trying to get an apartment that has an elevator, not stairs. So because her child is in a wheelchair, and the fact that, in many of these cultures as well, physicians are actually very respected in high regard. And so they often seek towards physicians to not just enable them to help with their health problems, but also with their social problems, because they see the connections that physicians have and also the allied healthcare team and so forth. And I think there is a lot of push right now to really ensure that medicine is social. And we understand that health is, in order for them to be able to achieve health equity, we have to take a responsibility and really, first and foremost, just validate and be like, yes, I understand your life is hard, and asking them, well, how can I support you, right? And why they're, and again, and that even just goes beyond like just referring to a social worker and so forth, right? Because often that can be seen as like, you're just pushing off the issues to them. But within a health system, as someone who's worked for, 10 years, like, I remember our most vulnerable patients. It was me, it was a physiotherapist, it was a cardiologist, it was a nurse practitioner. We were a team to support, and the social worker to support not their health, but their life from a holistic perspective. So again, I think when we think about bias, if we're only working at the individual level, whether as a practitioner or we see our patient only as at the individual level, if we're not going to be working as a unit, as an institution together, then how can we actually overhaul our health and social systems in a meaningful way?
Okay, thank you, Ananya, for sharing this from your own research experience. Now, this brings us to the end of our panel discussion. Thank you so much once again. And we will now be dedicating the remainder of this webinar to address some of the questions that the audience might have for our speakers. If you haven't gotten the chance yet, I'll remind you once more to please type in your questions into the Q&A chat box, and we will try our best to get to them. Okay, so our first question is, what strategies can researchers and healthcare providers use to ensure that experiences and needs of racialized immigrant women are meaningfully included in health research rather than treated as an afterthought?
I think Ananya sort of talked about this, where having immigrant women, racialized women as part of the team informing these research questions to ensure that there are questions that they want answered, and that they speak to issues that are most pressing to this community instead of speaking on their behalf, like doing research on their behalf.
I think also another important measure that us as future healthcare providers can take from now is enhancing our medical education with, learning also about medical ethics and the law behind these newly coming women, so that when they ask us how can you support us, instead of just referring them to a social worker, we can actually guide them towards like good resources, or we can tell them like ourselves about the law, the rights that they have, the resources that they can have access to without Medicare and stuff like that.
Okay, I have another question in the chat box. When medical evidence and clinical guidelines are known to be incomplete or biased, particularly for racialized immigrant women, what practical decision-making frameworks do are clinicians and frontline providers using today to reduce harm while stronger evidence is still being built?
So just speaking on behalf of myself and Maria, since we aren't working yet in the clinical setting, I think it's challenging for us to answer a question like this. Ultimately, as a clinician, you can just do the best with the research that you have at the moment and acknowledge limitations, as well as just the research that I've been doing over the summer was working on patient decision aids and educating patients on their condition so that they can participate in coming to a decision on their treatment rather than just providing paternalized sort of archaic care where you tell the patient what to do. So being humble, acknowledging the limitations and what you're able to provide based on the limited research for these like the limited data that take into account these populations, I think is the first step to establishing more equitable care for these groups.
Yeah, I also just wanted to make note, I've done a lot of work in diabetes and, work with a lot of endocrinologists. And, for me, a lot of my research has been focused on South Asian communities in Canada, given that they experience one of the highest burden of the disease, very in parallel with Indigenous communities. I think often when we are screening for diabetes, and if we, for example, use these screening tools, there has been a lot of frustration among my colleagues who are endocrinologists that these screening tools often, focus on which we need to look at, like risk factors, family history, and 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 like BMI, physical activity, and so forth. Understanding that yes, these are critical, like individual, clinical and behavioral risk factors, and definitely we need to take them into account, and they do perpetuate one's risk for diabetes. But a lot of these screening tools are actually failing, for example, the social determinants of health. And I know, particularly when it comes to immigrant women, for example, they experience a lot of food insecurity. They can't afford to be physically active because often they live in neighborhoods that are not conducive to walking. They can't afford to join a gym and so forth. And they have very high stress levels. And so many of us are actually pushing to, redesign the screening tools and adopt the clinical guidelines, particularly when it comes for diabetes, is to make sure that the social determinants of health is also being screened and really understanding that that also escalates their risk for diabetes.
Okay, our next question is, this person is saying, I often see racialized women, particularly immigrant women, being framed in research and clinical discourse as infantilized or inherently less capable of navigating healthcare systems, often attributed to language or cultural barriers. But as you've emphasized, these inequities are fundamentally political and structural. I get worried writing up research conclusions, especially in increasingly polarized political climate where even the terminology is contested, as in the US. Therefore, how can researchers responsibly describe communities as undeserved or marginalized without reinforcing these harmful narratives and pushing the honest back for change back on POC women?
I'm happy to answer this just because I do so much work in this area. I really, really, really appreciate this question. As someone who's been doing research for over 12 years, and I think about the earlier work when I was like a master's student, PhD student, focusing work on health disparities among immigrant women. Yes, you're completely like it was very frustrating to have articles to cite that only really blamed and shamed immigrant women for not being able to access healthcare that was attributed to their language and cultural barriers. We've come a long way. We're really starting to shift the dialogue towards really understanding it is political, it is structural. But I understand also, and I don't know if this individual is a researcher, obviously there's a lot when we work in academic institutions, whether it's affiliated academic hospitals or within our own universities like McGill and so forth. And so, as researchers, we're also taught not to be political, right? And I think I understand your worry, but for me, more than ever, whenever, because I write so much about health disparities in research, I've actually stopped using the word culture in a lot of my work because it's so saturated in the literature, and that's what people think about right away. Um, but I think we have a case and we have a lot of evidence that we can draw on that disparities are a result of political climates, of laws, and it's driven structurally. And I would actually say we need to bring this critical narrative more than ever, given the strong and growing anti-immigration sentiments that are happening, and the laws that are being passed in the US. For example, this week, there's a ban of 75 countries where people are going to be unable to apply for visas to come to the US. This is really alarming, not the policy in itself, but just kind of reiterating this message that is growing, that immigrants are bad for our societies, right? And we need to overcome that harmful narrative, because that is also trickling down to our health systems as well. And I think we need to actually emphasize that these health disparities are a result of our social conditions in society. And we have a ethical and moral responsibility to name it in the introduction and in our conclusion, even though necessarily we may not be able to study it, which is really hard from an epidemiologic perspective. But if these are narratives that are coming up from qualitative interviews, we have to mention it, because that is ethically what is right to do. So I appreciate this question. I'm really talking just based on my experiences, but also if you're taking a true community engagement partnership approach, I see more and more of the immigrant communities I work with, they want the true narratives, the truth in our papers. They're tired of being blamed and shamed through the research. And it's just going to perpetuate more harm in these communities.
Okay, we have time for one more final question from the Q&A, and then we'll wrap it up. Thank you again. This is a very interesting conversation that's happening. So are clinicians and frontline providers, do clinicians and frontline providers have enough sensitivity training to seek appropriate and suitable non-traditional framework? And this is a follow-up, sorry.
Oh, sorry. I was just going to
Sorry.
answer from a medical student perspective once again. We have limited sensitivity training as to approaching non-Western biomedicine perspectives to healthcare. However, we did have a 2-hour session at the end of our neurology block, which talked about different religious perspectives in healthcare. I believe we had somebody from the Jewish community come speak, Christian community, as well as different cultural groups in Canada. There's people from different Caribbean nations who also came to speak. That was super helpful. I mean, I think you can always learn more about different cultures and their approach to care, and it's really just about being humble and receptive and understanding that that their perception on healthcare is valid and unique, and to try to find a solution that takes into that collaborates two worldviews, and that if something they're doing isn't harming them, although it might not be promoting their care in a way that we think of as traditional, peer-reviewed science, it doesn't mean we should inhibit them from doing that.
One more thing. Thank you, Zoe. It was very interesting. One more thing I would have to say to that is, our school is very much based in the Western scientific ways. So that means that the core of our studies is very science-based. Everything has to be peer-reviewed science articles. When, for example, dealing with hip osteoarthritis, we are told that surgery is the best, and then there's hyaluronic acid injections, corticosteroid injections. But for example, if someone came and said that they're not very comfortable with that and would rather take a more traditional supplement, a Nerva something like that, I don't think our education covers that much. And I think that this is something that we really have to improve and acknowledge that Quebec is a very pluralist society, so many cultures, so many religions. It's very difficult for us to take into account all of that in our education, but it is something that we 100% have to improve, look at more research, especially in more Eastern, traditional medicines, so we are able to include everyone, and so that they don't feel uncomfortable when the only alternative for them is surgery.
Okay, well, that brings us to the end of today's question and answer session. Thank you so much for your important questions. We've also reached the end of today's webinar. On behalf of everyone, excuse me, we thank WHAM's team, Zoe and Maria, and Dr. Ananya Banerjee for taking the time to participate in today's webinar. We value your knowledge and your expertise. Thank you again to all of you for attending today's webinar. We hope that this session inspired continued reflection, dialogue, and action in your communities. There's an evaluation link in the chat box. It'll pop up again once the webinar ends. Please fill it out as this form. Please fill out the form as your feedback is going to guide our future webinars. Thank you once again for joining us and have a great rest of your day.